Alright, let's talk about indications for outpatient antenatal fetal surveillance. Rationale. So 6 out of 1,000 stillbirth is the regular rate for 20 weeks in general population. At 42 weeks is 1 out of 1,000. At 41 weeks is 0.6 out of 1,000. At 40 weeks is zero point 0.4 out of 1,000, and 39 weeks is 0.3 out of 1,000. False positive rate for a BPP is 0.8 out of 1,000. So this is for BPP and modified BPP. So surveillance is recommended if the risk is greater than the false positive rate, or it's 2 times the risk of stillbirth compared to if the patient doesn't have the condition. Timing, usually starting at 32 weeks is sufficient. Less than 32 weeks is very normal to have non-reactive NSTs. 50% of fetus between 24 to 28 will have non-reactive NSTs. 15% between 29 and 32. Therefore, before 32 weeks, we can use 10 by 10 instead. The test can be done weekly unless it's high risk or very high risk or there's multiple risk factors. So what are some of the fetal conditions that will require antenatal surveillance? So FGR for sure. Less than 10 percentile, there is a 10 times risk of stillbirth compared to normal weight at the same age. Less than 10 percentile is 4 times the risk. Umbilical Doppler is primary modality for surveillance in FGR patients. Absent or reversed end diastolic flow is associated with additional frequency of perinatal mortality. If these patients are not delivered, they should be inpatient with twice weekly antenatal fetal surveillance after diagnosis. So FGR, other fetal conditions, multi-gestation, decreased fetal movement, fetal anomalies, and congenital infections. Okay, let's go back. So FGR, we just talked about multi-gestation, stillbirth rate for a di-di twin versus a mo-di. At 35 weeks is 1 of 1,000 versus 3 out of 1,000. At 36 weeks is 2 out of 1,000 versus 5 out of 1,000. At 37 is 3 out of 1,000 versus 10 out of 1,000. So di-di twins, we should start weekly NST at 36 weeks. Modi, we should start at 32 weeks. Start ultrasound at 16 weeks every 2 weeks to watch for signs of twin-twin transfusion. Decreased fetal movement, one-time antenatal fetal surveillance do not need to be repeated. Fetal anomalies, trisomy 21, 10% stillbirth rate, decreased after 37 weeks, 50 out of, increases after 37 weeks, up to 50 out of 1,000. So these patients the antenatal fetal surveillance is individualized. So for congenital infections, parvovirus B19 infections, there is a 6% stillbirth rate. We should do serial ultrasounds and MCA Dopplers for fetal anemia and high drops. So what are some of the maternal conditions? So obviously hypertension, diabetes, SLE, APS, sickle cell renal disease, thyroid, IVF, smoking, alcohol, polysubstance abuse, BMI, and maternal age. So let's go back and go through them. Hypertension, chronic hypertension, 25 out of 1,000. Superimposed preeclampsia, 100 out of 1,000. Gestational hypertension without severe ranges, 30 out of 1,000. So gestational hypertension without severe ranges, they should be having twice weekly surveillance. If they have severe ranges, the stillbirth rate goes up to 50 out of 1,000. So they should have daily surveillances. Diabetes, if they're controlled on medication once or twice weekly at 32 weeks. Poorly controlled, they should definitely be twice weekly at 32 weeks. Pre-gestational, stillbirth rate is 15 out of 1,000. So they should have also twice weekly at 32 weeks. SLE, stillbirth rate 100 out of 1,000. So they should have NST, weekly NST at 32 weeks. APS, 200 to 300 out of 1,000 depending on number of antibody. Start 32-week twice weekly testing. Sickle cell, 80 out of 1,000. Once or twice at 32 weeks. Renal disease, if creatinine is 1.4 or more, we should start once or twice testing at 32 weeks. Thyroid disease, if well controlled, no need for antenatal surveillance. IVF, 10 out of 1,000. So weekly NST at 36 weeks. Smoking, no data for increased surveillance. Alcohol, 15 out of 1,000, 3 times. The average, 3 times the normal stillbirth rate. Only if you drink 5 or more drinks. Weekly testing at 36 weeks. Polysubstance abuse, no data, only if other perinatal mortalities. BMI 30 to 40, weekly NST at 37 weeks, 40 plus, weekly NST at 34 weeks due to 2.5 times increased risk. Maternal age 40 plus, NST at 37 weeks. OB conditions. So what are some of the OB conditions which you think about? Prior stillbirth, preeclampsia, or FGR, ICP, late term or post term, serum marker elevated. So let's see. So prior stillbirth, 5 times more likely. Once or twice weekly at 32 weeks, or start 1 to 2 weeks before the prior stillbirth age. Preeclampsia, 32 weeks weekly or bi-weekly. ICP, if the level is 40 to 99, there's a 3 out of 1,000. If greater than 100 is 40 out of 1,000. Recommendation is 2 times weekly NST at diagnosis or when delivery is considered. Late term or post term, 41 weeks, should be getting once or twice weekly testing until 42 weeks. Then delivery is indicated. Serum marker, elevated AFP, 30 out of 1,000 chances if the level is 2.5 multiple of mean. However, no surveillance unless there is IUGR or FGR. PAP-A, if decreased PAP-A 0.4 of multiples of mean, there's a up to 9 times the risk of stillbirth. Inhibin, 2 times risk if it's 2 multiples of the mean. So if the PAP-A or inhibin is abnormal, we should start antenatal testing at 36 weeks. Weekly testing. Placental or amniotic fluid condition. Chronic placental abruption, vasoprevia, placental or cord abnormalities, oligo, poly. Chronic placental abruption, 8 times more likely to have stillbirth. It is individualized. Vasoprevia, close inpatient surveillance, starting 34 to 37 weeks. Placental or cord abnormality, filamentous cord 4 times. Single umbilical artery 4 times. So these should have weekly NST at 36 weeks. Oligohydramnios, 15 out of 1,000. Once or twice weekly upon diagnosis. Polyhydramnios, 3 out of 1,000 at 39 weeks. If it's 12 cm or more on single deepest pocket, we should have once or twice weekly NST at 32 weeks.